Okay, good evening, everyone. Can you hear me?
Yes,
Yes,
good
we can.
evening, Prof.
All right, thank you. Can you see my slides too?
Yes, we can see
Yes,
your
Prof.
slide.
Okay, so we'll go ahead. So this evening, we're supposed to have two lectures. I don't know. Is that correct?
Yes, Prof. We were supposed to have two lectures today.
I'm supposed to give you two lectures.
No, please. Yours was scheduled from 7:30, but we had one for Dr. Hart. Was supposed to start from 6:30.
Okay.
Yeah.
Okay, when am I supposed to give you the second? Because I saw two topics there on the timetable.
Sometime next week. Sometime next week.
Okay, that's fine. So let's
Uh,
go ahead with this one. So we're going to be talking about care of the newborn, and then we're going to emphasize care of the baby with neonatal jaundice. So we'll start with an overview. I'm Professor Opara from Pediatrics and Child Health, University of Port Harcourt and Teaching Hospital. So I'll go with the following outline. Just as a way of introduction, when we say newborn or neonate or the neonatal period, we're talking about babies within the ages of 0 to 28 days. So the newborn or neonatal period is the period from the first day of life, from birth to 28 days of life. And annually, there's a high newborn death rate. And neonatal mortality amounts to up to 47% of all under 5 deaths. So when we're talking about reducing under 5 deaths, a huge percentage of deaths occur in newborns. So they contribute more or mostly to deaths in the under 5 age group. So globally, there are about 2.4 million neonatal deaths as of 2019. The story has not changed much till date, and about 1/3 of the babies die on the day of birth, while close to 3/4 of the babies die within the first week of life. So the most important time in the life of a baby, the most vulnerable, is the first day of life and actually the first week of life. So if we get most of our babies to survive for the first week of life, a lot of them will survive until they are 5 years old. So sub-Saharan Africa had the highest neonatal mortality rate, and we still do. And contributing to this, most of these deaths are found in countries like Nigeria. A child born in sub-Saharan Africa or Southern Asia is 10 times more likely to die in the first month than children born in high-income countries like the USA, the UK, and other developed countries. Incidentally, children who die within the first 28 days of birth suffer from conditions and diseases associated with lack of quality care at birth or skilled care and treatment after birth. So a lot of the causes of these deaths are actually preventable if these babies have access to skilled care at birth and proper treatment immediately after birth in the first days of life. So we can see that if we look at number of newborn deaths per 1,000, Nigeria is second to India in the world, and the numbers are still approximately the same today. So what are the causes of death in this age group? Babies who are born too early, which we will usually call premature babies. Babies who are born too small. So if a baby is too small, either because he's premature or he hasn't grown well before birth. So a baby can be carried for 9 months and it comes out too small. The usual birth weight is 2.5 kg and above. So any baby born at a weight of less than 2.5 kg is likely to die for early in life. And then babies with infections, babies with asphyxia, those are those that are unable to cry at birth or initiate spontaneous respiration at around birth. So care of babies after birth by health workers and mothers is what we call essential newborn care. And if essential newborn care is properly done, it promotes the health and increases newborn survival. Majority of mothers and newborns in low and middle income countries do not receive optimal care, and that is why neonatal mortality is highest in low and middle income countries. So what is essential newborn care? We've said that it's the care given to babies at birth by skilled health workers and their mothers. So all newborn babies should receive the following care. First is thermal protection. Now, babies, as we know, are born wet because in utero, that's inside the womb, they are inside a bag of fluid, which we call amniotic fluid. So once they are born, they are wet. And one of the ways to protect them is to make sure that they are thoroughly dried and kept warm. And then if they are dry and kept warm, they are less likely to die because cold is not friendly at all with babies. And any baby exposed to cold at birth may develop more serious problems and die if not properly taken care of. So for thermal protection, we talk about immediate and thorough drying of the newborn, promoting skin-to-skin contact between the mother and infant. We'll talk a bit more about this. And then hygienic umbilical cord care and skin care. Now, babies are very prone to infections. They can get infections easily through the umbilical cord and through the skin because their skin is thin and fragile. And so if we fail to do umbilical care hygienically, they can be exposed to infections and they can die easily. Then nutrition is very important. And for newborns, we talk about early and exclusive breastfeeding. We'll also talk a bit more about that. And then we need to assess them for signs of serious health problems or any need for additional care, especially those that are low birth weight, that is, those that are born too small, those that are born sick, or those that are born to HIV-infected mothers.
In progress.
Then there are also preventive treatments that we give routinely to these babies at birth, and we'll talk a bit more about that. So what is the care that we give to them at time of birth? Very, very importantly is taking care of their breathing problems. The first 1 minute of life in the life is called the golden minute. Golden in the sense that what every baby should be made to breathe either by himself or assisted within 1 minute of life. If that is missed, that baby can develop problems that can lead to death or lead to neurological problems in the future. So breathing is one very important aspect of the care of the newborn. So when a baby is born, usually we'll say, oh, the baby has cried. And every time a baby is born, we are all listening to hear the cry of the baby. When a baby cries, we know that the baby has taken in the first breath, good breaths, and is able to cry. Now, if a baby is unable to cry, we should assess immediately after birth. Recognize those that have breathing problems, those that are unable to breathe by themselves, those who are breathing but breathing with difficulty or gasping or breathing very poorly. And so we need adequate resuscitation equipment. In the photograph, we will see what we call the bag and mask, which we use for ventilating babies. So if a baby is unable to cry within the golden minute, there's a problem and we must initiate breathing within that first minute of life to avoid problems. So that means that when a baby is born, there should be adequate resuscitation equipment. And the most important equipment is what is shown in the photograph. It is the bag and mask. We should have the proper size. We should have the proper skill to use this bag and mask. And it means that if the baby is unable to breathe by himself, we should use this bag and mask and initiate breathing within the first minute of life. Because when babies are unable to breathe at birth, they have good hearts, they are having respiratory problems, and we need skilled birth attendants to be able to do this. Now, the reason why a lot of babies will die is because they are being delivered in places where there is no skill to take care of these problems. And so in some of the maternity homes with the traditional birth attendants, when a baby has these problems, they are unable to take care of them. And then by the time the baby gets to the hospital, sometimes it's already too late to recover, or the baby has already developed problems which he may have for the rest of his life. So at the time of birth, we talk about the golden minute. All babies must be breathing spontaneously or assisted to breathe within the first minute of life. The next thing that is important for babies at the time of birth is provision of warmth. Like I said, they come out from a bag of amniotic fluid, so they come out wet. This photograph shows different methods in which babies lose heat at birth. So because they are wet, when they come out, they can lose heat by evaporation. If you remember our secondary school, I think biology or chemistry, we'll say that evaporation causes cooling. So if a baby comes out and it's not quickly dried, the fluid evaporates and the baby gets cold. They can lose heat to the surrounding areas by radiation. They can lose heat to the substances or surfaces in which they have contact by conduction. And then they can also lose heat by convection. By convection, that's if the air around them is cold. So it means that babies should quickly be dried to avoid evaporation. They should be born in warm areas, so the windows should be closed. And then if they are born in theaters, at the time the baby is to be born, the AC should be put off. This is one problem we usually have with surgeons, because surgeons do hard work, they sweat in the theaters, but when a baby is going to be born, by all means, the AC should be off, windows should be closed. We don't want air currents around the baby, because babies easily lose heat. And then they can also lose heat if they are placed on cold surfaces. So they lose heat to those cold surfaces by conduction. So because we know that babies lose heat, we have to take extra care to make sure that the room is warm. The towels that we use to dry them are warm. And then when they have been dried with wet towels, we quickly remove them and put them on dry towels. So the clothes we use to receive the babies should also be warm. Sometimes you find babies who are transported in the same clothes that they came out, they were received with at birth. And by the time they get where they are going, the cloth is wet, the baby is cold, and that can cause a lot of morbidity for the babies. So this again shows how they lose heat. So the warm chain is a concept introduced to describe a set of interlinked procedures which will minimize the likelihood of hypothermia, that is low temperatures in the baby. And failure to implement any of these procedures will break the warm chain and increase the possibility of undesirable cooling of the infant. And the warm chain follows the following procedures. So like I said, babies should be born in warm delivery rooms. There should be immediate drying, and immediate drying with warm towels. So every time a baby is born, we should have at least 2 sets of warm towels, one for immediate drying and then immediately changing to warm towels after that. Then skin to skin contact, we'll talk about that a bit more. Breastfeeding is also a means of providing warmth for the baby. And then we should postpone bathing and weighing of the newborn. Now, this is one procedure that a lot of midwives are stuck with. Immediately babies are born, they want to give them a bath quickly. Babies don't need to have a bath within the first 24 to 48 hours after birth for several reasons. One, bathing would increase the risk of evaporation, because we are going to pour water on the baby and then it's going to get cold. And then secondly, the baby is born with a coat, that like this creamy substance, which we call the vena caseosa, on the baby's body. It helps to keep the baby warm, and it also helps to protect the baby against infection. So as much as possible, we want to leave this vena caseosa on the baby's surface, and within the first few days it will clean out by itself. There's this misconception that if you leave that on the baby, it's going to develop body odor and all that. It's a misconception. Babies do not need to have a bath within the first 24 to 48 hours of life. We don't need to weigh them immediately after birth, because remember, even the weighing scale is cold. So as much as possible, we want to prevent putting them in contact with cold surfaces. Then we need to put them on appropriate clothes, well covered, the head well covered, stockings, and then the beddings, everything around them should be warm. It is good practice to keep mother and baby together, because baby gets warmth when he's in contact with the mother's body. And for babies who need resuscitation, as much as possible, they should be resuscitated under a warm area. In places where they are resuscitated, the resuscitate should be on to provide warmth. And then, of course, it's important to train those that have contact with these babies, those that deliver babies. Everybody should be aware that babies need to be kept warm immediately after birth. Now, this is like a delivery room. We can see that there's a resuscitate there where the baby should be resuscitated. So it should be on and kept warm. We should have a temperature monitoring of the room. The windows should be closed, the AC should be put off. So there should be a consciousness, an intentional effort to make sure that the room and the surfaces are warm, where babies are taken care of. Then we also talked about keeping mothers and babies together. Now, this position is called the kangaroo position. It's been derived from the kangaroo, where the newborn, kangaroos have their newborns born prematurely, and they have a pouch in front of them where the baby stays and is kept warm until the babies are born. So this concept is what we use to do kangaroo mother care. So the baby is placed in this position, skin to skin with the mother in between the breast, the head turned to one side to allow for good ventilation. The baby is in frog-like posture, the bottom is supported, and the baby is placed between the mother's breast. So this baby can be wrapped in this position as soon as possible after birth. And then with a cap on the head, it keeps this baby warm. So this picture shows how to hold the infant in the kangaroo mother position. It's one of the best ways of keeping a baby warm, and it's much better than wrapping a baby and dropping in a cot. And this is very important, especially for low birth weight babies. This picture shows that even a woman that has multiple babies can keep them in kangaroo position. You can see this woman is carrying triplets. And then even fathers can carry their babies in kangaroo position. It keeps them warm. It improves bonding between fathers and their babies as much as it does between mothers and their babies. And most importantly, these babies are kept warm. So babies who are born in places where they need to be referred for more advanced care should be transported in the kangaroo position rather than being wrapped in warm clothing. And if the mother is too ill to move with the baby, then the next available caregiver can carry this baby in the kangaroo position. And we have found out that when babies are transported in this position, by the time they get to the place where they need, where they are going for care, the outcome is usually better because they arrive there warm and in better condition. Then we talk about early and exclusive breastfeeding. Like we know, breast milk is the perfect source of nutrition for babies. And the colostrum, which is the first breast milk, is also referred to as liquid gold. So breast milk is best at any time, and it should be initiated early, within the first 30 minutes of life. So as soon as a baby is born, it should be taken onto the mother's breast, even before the mother leaves the delivery table. Early initiation of breastfeeding leads to successful and exclusive breastfeeding. And when we talk about exclusive breastfeeding, we're talking about breastfeeding exclusively for the first 6 months of life before adding on to other sources of nutrition. It encourages mother-infant bonding. It helps uterine contraction. And like I said, it's a perfect source of nutrition, complete and available at any time for the first 6 months of life, and also very nutritious up to the first year and the second year of life. So there are very many advantages of exclusive breastfeeding, both to the mother, to the baby, and even to the family, in terms of cost and then in terms of health issues, because babies who are exclusively breastfed have lower case incidence of infection, they grow better, and then it has also been known to give them better IQs. Now, skin-to-skin contact, apart from keeping the baby warm, also promotes breastfeeding. So babies who are placed skin-to-skin on their mother's chest after birth will initially cry briefly, and then it's a very distinctive cry. Now, there's this practice also in the delivery room where the nurse would, immediately the baby is born, they remove the baby, bath, wrap, and keep far away from the mother. The current way of taking care of a baby is immediately the baby is born, he should be placed on the mother's chest. Initially, what happens is that these babies will cry very distinctively. Then they enter a stage of relaxation, recovering from the birth process, and then they wake up. And you notice that as they wake up, they begin to move spontaneously towards the breast. If you watch it, it's actually very intriguing. As they begin to move, they actually start to crawl towards the breast. And once the baby has found the breast, which is his food source, there's a period of rest. So after resting, the baby will explore, get familiar with the breast, and begin to actually smell and lick and then attach to the breast. A lot of times we remove the babies from the mothers and the baby misses this. After the initial breastfeeding, they now get into a sleeping mode, and then they can be taken off the breast. So skin-to-skin contact does promote breastfeeding. Another care that the baby needs at birth is eye care. Some babies may be born, and then as they go through the birth canal, they can acquire eye infections. So routinely, eye care should be done within 60 to 90 minutes of birth. Careful hand hygiene is very important, and the recommended drug or ointment for the eyes is 0.5% erythromycin. It helps to prevent serious eye infections in the newborn. Next is cord care. Remember again that I said that the umbilical cord is a source of infections. And whoever is handling babies at the time of birth must have their hands washed, because our hands easily transmit infection to these babies. So we will wash our hands in every care that we're giving to the baby, whether it's routine drying, whether it's cord care or eye care. Hands must be washed properly with soap and water or sanitized before attending to the baby. And the recommended drug for taking care of the cord is chlorhexidine gel, which is applied around the umbilicus. Babies also need vitamin K at birth. Vitamin K1 will protect babies from serious bleeding. So routinely, all newborns should have 1 milligram injection of 1 milligram of vitamin K on the front outer mid-thigh, and it's usually given around 90 minutes of birth. Again, hands must be washed with soap and water before this procedure is done. And then every baby should be examined at birth, because at the time of birth, a lot of problems, if present, can be noticed. And if this examination is missed, a lot of problems will go unnoticed, and by the time the baby comes back, he may have developed complications. So observation is also a way of listening to the baby. The kind of cry can tell if a baby has problems like hypothyroidism. Obvious problems can be seen. Is the head swollen? Do the eyes have problems? Does the child even have congenital abnormalities? That is the time to look out for those things. So the first examination of the baby is the most important examination of that baby. And baby should be examined naked from head to toe. Of course, under a radiant warmer or in a very warm environment. And this examination should be done quickly. So we look, we listen, we touch, and then where necessary, we use other equipment to check if the baby has problems.
Lisa's Prof mic gone inactive.
I think we have lost her.
Sad. No.
Hello,
Welcome back.
can you hear me?
Yes, Prof.
Loud
Yes,
and clear.
Okay, sorry.
We are
we
hearing
lost
you
Sorry,
now.
I got
internet.
logged out. Where did you the previous slide?
Examination.
It's
Okay,
okay,
we
our
are here.
network is
Yeah.
Yes, yes.
Okay, this is where we got logged off.
Yes,
Yes,
ma'am.
Okay. Okay, so I was talking about examination of the newborn, and I said the first examination of the babies, one of the most important examinations in the life of a person, because that first examination can help us detect early problems and manage them before they become complicated or cause problems. And if there are certain problems, if they are missed at the birth of the baby, can result in lifelong complications. So observation is also a way of listening to the baby. We look for obvious problems. obvious problems and make sure that everything we see is recorded. Obvious problems may be important or unimportant in quotes. For example, if a baby has extra digits, they are obvious, you see them and record them. And it's important to record these things so that people don't come back later and start to ask, are you sure this is my baby? So we look for obvious problems. And like I said, babies will be examined naked in a warm environment. So babies should be examined from head to toe. So we look at obvious problems on exposed areas, listen to the heart, because that may be the time you can detect that the baby has a congenital heart problem. And then we inspect for obvious problems. For example, a baby can have an excessively large head, or he may have problems with the limbs, or the tongue, or the eyes. Those are obvious problems. And then when we listen by auscultation or we touch, we examine, we may detect other problems. And then we will need clinical aids like the use of touch, ophthalmoscope, and spatula if indicated. There are certain special tests that we can also do to rule out congenital anomalies. And then sometimes too, from examination, we can be able to tell what the actual gestational age of the baby is. So by examination, you can tell a baby who is born premature or has stayed too long in the womb. So examination can give us a lot of information that for the baby, and it may help us to detect and treat problems early. So within the first 90 minutes of life, we're doing continuous skin to skin care. We have to maintain the baby's temperature. That is the time to weigh the baby, not immediately after birth. And within the first day of life, we should have started immunization, routine immunization. So at birth, we'll give BCG and hepatitis B and the rest of them. And then we have to support this woman to breastfeed the baby, because remember, we said early and exclusive breastfeeding is the best form of nutrition for these babies. And then we also need to advise the mother about breastfeeding problems, and then examine the baby. And then at discharge, we reassess and give parents guidance for home care and give them appointments for when they should come back. So now we'll talk about neonatal jaundice, which is a common problem worldwide. In Nigeria, it accounts for about 23 to 60% of admissions in the special care baby unit. More than 60% of term, that is babies born at full maturity, 9 months, and 80% of babies born preterm would present with neonatal jaundice. It is a commonest condition requiring medical attention in newborns. And it is important because if the babies don't get proper treatment, it could lead to lifelong neurologic complications. And these babies who have been born apparently normal can become disabled for life. So what is jaundice? It is a descriptive term that refers to the yellowish discoloration of the skin and the eyes in the baby, and is due to deposition of the pigment called bilirubin, which is a breakdown product of heme from red blood cells. So jaundice can be classified as either physiologic or pathologic, and this is where the problem usually is. A lot of times when babies have jaundice, a lot of health workers assume it is physiologic. Physiologic means that it is part of the normal physiology of the child and it will certainly resolve. But it's important to note that until you have done a jaundice test, you cannot assume that jaundice is physiologic. That assumption has led to serious problems and sometimes death in babies. So jaundice can be physiologic or pathologic, and it can also be classified as conjugated or unconjugated hyperbilirubinemia. So the difference between physiologic and pathologic jaundice. Physiologic jaundice appears usually from the second day of life, that is after 24 hours. Usually gets to the peak around the 4th to the 5th day in the term baby, and to the 7th day in a preterm baby. Usually, serum bilirubin levels are within normal limits for the age in hours, and usually by 14 days, this jaundice has disappeared, and usually will disappear without any form of treatment. Pathological jaundice, on the other hand, is a more serious type of jaundice. Now, any jaundice that is seen in a baby within the first 24 hours of life is pathologic, and we must pursue it and treat it aggressively. Usually, the serum bilirubin levels increase very fast, and the bilirubin levels get to very high levels for the age. And then any jaundice persisting beyond the first 14 days in a full-term baby is pathologic. So any baby who is 2 weeks and still has jaundice has serious issues that should be addressed. And then if a baby has jaundice and the stool color is clay-colored or tending towards white, and the urine is staining the clothes yellow, we should look for the cause of that jaundice. Usually, newborn stool is yellowish in color. So once that color tends to start becoming very light towards white, we should look for the cause of jaundice. And then if direct bilirubin is more than 2 milligrams per dl or 20% of the total, then jaundice is pathologic. This is bilirubin metabolism. This is normal physiology, how red blood cells break down, release substances which are eventually converted to unconjugated bilirubin, which is what stains the baby's skin and eyes. Somebody is talking. All right, so I'll talk a bit more about physiologic jaundice. So usually it's characterized by its appearance in a well baby, occurs after the first 24 to 48, so usually by the 2nd to 3rd day of life, reaches a peak by about the 4th day and disappears within 7 to 10 days. And if you check the levels, it's usually below 170 to 200 micromoles per liter. Now, again, I will emphasize that if a baby has jaundice, we cannot assume it's physiologic until we have done the test to show the level of bilirubin. Because what may start looking like physiologic jaundice may end up getting to very high levels, which, if is not treated, can damage the baby's brain. The reason why we treat jaundice so aggressively is because it has the capacity to destroy the baby's brain. And once that baby's brain is destroyed, it is for life. There's nothing that can be done. So we have babies who come because of jaundice. They have delayed developmental milestones, and they can never reach their potentials in life. In the preterm baby, the jaundice occurs a bit later, peaks around the 7th day, and then clears about the 14 days. Remember, when we say physiologic, we are just saying that it is due to the normal physiologic processes in the baby, and the baby is otherwise well. So once you see a baby that has jaundice with a fever, that has jaundice, is feeding poorly, that has jaundice, is not breathing well, or has rashes, or has anything that is making the baby sick, it is not physiologic jaundice, and that baby must be investigated and treated properly. So why do babies have physiologic jaundice? Now, the enzyme that converts bilirubin from the unconjugated form, which is the dangerous form, to the conjugated form. When I say dangerous form, it is the unconjugated one that has the capacity to damage the baby's brain. Now, when they are born, the enzyme that converts this unconjugated form to the conjugated form is very low. The levels are very low in the baby because in utero, it is a placenta that clears. The mom clears the baby's bilirubin via the placenta. At the time of birth, before the birth, this enzyme is inactive. And so once you cut the baby away from the mother, once the placenta is, the umbilicus is cut, the baby has to start to produce this enzyme enough to clear the bilirubin. And it takes a few days for this enzyme to regain function and begin to function optimally. So because of that, the baby is unable to take care of the bilirubin in the first few days of life. But when we say physiologic, as God would have it, within the first few days, the levels are low. By the time the enzyme gains function, it's now able to start clearing away the jaundice. But if for any reason the amount of bilirubin being produced is so heavy that, and for the baby, then the levels will get very high and the baby is unable to clear this bilirubin. So why are babies prone to physiologic jaundice? Their red blood cells have shorter lifespan than adult red cells. So red blood cells in the newborn takes 80 to 90 days. They die off after 80 to 90 days compared to 120 days in older children and adults. In the preterm infants, it's even less. It will take like 60 to 80 days. So they are more prone to jaundice. And then there's also low conversion of bilirubin to the form in which it is excreted by the intestine, because at the time of birth, they have very low levels of intestinal flora. That's the good bacteria in the gut. And so because of this, there's a lot of bilirubin that goes back into circulation. Now, pathologic jaundice, any baby who is ill and has jaundice, we will assume that that jaundice is pathologic, because once a baby is sick, the tendency for bilirubin, the unconjugated form, to cross into the brain is higher. And I said any visible jaundice present within the first 24 hours of life is pathologic. And when the bilirubin levels are rising at greater than 85 micromoles per liter per day, it is also pathologic. Usually the bilirubin rises at high levels, and any values more than 210 in any baby by the third day of life is worrisome. Persistent jaundice beyond the 10th day. Remember that in the 10th baby, physiologic jaundice should have cleared by the 10th day of life. So any jaundice beyond the 10th day, or any jaundice that improves and then starts to appear again, is pathologic. And then when the conjugated forms are too high, it's also pathologic. What are the reasons for pathologic jaundice? There is increased production of bilirubin, because anything that is happening with the baby, maybe the baby is breaking down his red blood cells at a very high rate, so there's increased production of bilirubin and release into the blood. For some reason, the hepatic enzymes are not active or functional, or there's a problem in the baby and there's conjugation, normal conjugation is not taking place, or even after conjugation, there's impaired excretion. For example, sometimes the bile ducts are blocked congenitally, so they are not excreting the bile, or bile flow is sluggish, or for any reason, bilirubin keeps going back into circulation, especially in babies that have intestinal obstruction. All these are reasons why they will have high bilirubin levels. So the causes generally are hemolysis, which can occur from blood group incompatibility. So usually the mother's blood group is O and the baby is A or B. And so there is breakdown of the baby's red blood cells because of incompatibility of the blood group. Sometimes too, the mother is resource negative and the baby is resource positive. So all these things need to be done. Once a baby has jaundice, we want to know the mother's blood group. We want to know her resource factor, and then other enzyme deficiencies like G6PD deficiency. Babies with G6PD deficiency usually break down their red blood cells when they're in contact with substances like naphthalene balls. Naphthalene balls are the usual camphor balls that some people use to store their clothes. So those babies, once they come in contact with those things, they begin to break down their red blood cells and they will continue to have jaundice. Then infections in our environment, infections are very common, and that is why when babies are born, as much as possible, we should have clean environment, clean hands, so that we prevent infections. Because once there's an infection, it can break down their red blood cells and increase their risk for jaundice. Sometimes too, when the baby's red blood cells are too high, like can happen in twin transfusion. In twin transfusion, one twin tends to give blood to the other twin. So one has a lot of blood, the other one has too little. The one that has too much blood will eventually break down the red blood cells and have polycythemia. Then when babies also have injuries and like Kefa hematoma, some babies are in the process of birth, can get birth injuries. The head is swollen. Wherever blood is accumulated, eventually it will be broken down and increase the risk for jaundice. So babies with intestinal obstruction are also at risk. So, but what are the common causes of neonatal jaundice in our environment? Prematurity, like I said, the smaller they are, the more prone they are to jaundice, because the liver is even more immature and is unable to handle bilirubin. Then ABO incompatibility, in which the mother is usually O and the baby may be A or B. And then sepsis or infections and G6PD deficiency. G6PD deficiency is very, very common in our environment, and it's usually X-linked disorder, so it's more common in males. Then factors that will exacerbate neonatal jaundice. If the baby is born asphyxiated, so those babies that did not cry at birth, if they have jaundice, the risk of brain damage is higher with those with asphyxia, acidosis, infection, dehydration. So once a baby is sick and has jaundice, the risk of the bilirubin getting into the brain to cause damage is higher. And so we cannot see a baby who is sick and say, oh, this jaundice is mild, and we will not treat. You put that baby at serious risk. So how do we detect jaundice in babies? By blanching the skin, that's applying pressure on the skin. When you apply pressure on the skin, it reveals a yellowish color on the underlying skin and subcutaneous tissue. So the skin, we can see jaundice first on the face and then down to the trunk and the legs. So jaundice progresses in a cephalocaudal manner, that is from the head first, the face first to the trunk, and by the time you can blanch the extremities and see that yellow discoloration, that jaundice has got very far. Okay, so what do we look at? The color. We should check for jaundice with the naked eye, better in bright natural light. A lot of babies are born and nursed in dark rooms, and so jaundice may not be noticed until it's actually late. So we need to examine the eyes, the gums, we need to blanch the skin. And like I said, it progresses from head to toe. So if you're seeing it only around the face, it's milder than if you're seeing it at the trunk and down to the legs. So it's important to check. But it's also important to remember that in our environment, babies can be very dark and you may not be able to appreciate it on the skin. And that is why every time we notice that the child has jaundice, especially from the eyes, we must do the test to check the levels. Other features include drowsiness. Baby is difficult to rouse, is not waking up for feed, is sucking poorly. That tells you that there's already a problem. By the time the baby starts to have convulsions, the jaundice has gone so far, and it may be a cause of mortality or serious morbidity. So we look out for other signs of infection and other problems in the baby. So this is a picture showing what we call the Kramer's rule. So the face is zone 1. So if jaundice is only seen in the face, it's less serious than jaundice that you see at the foot. So depending on where you see, so it progresses from head to toe. So, but by the time it's affecting the limbs, because the limbs, both limbs, usually are affected at the same time. By the time it's affecting the limbs, it's already gone very far. Now, this baby is a typical example of a baby with jaundice. Unfortunately, some people may pass this for a baby who is yellow. You think the baby is fair-skinned. The baby is dying already from jaundice. So it's important at when the baby comes to find out when it was noticed, whether they are using camphor balls, and then we examine the baby to look for other problems, signs of infection, fever, and every other problems. We want to do investigation to check for serum bilirubin, the blood group of the mother of baby, the blood levels, the part cell volume, because usually the baby is breaking down red blood cells, so you may have low blood levels. And then we'll do other investigations if indicated. The treatment for jaundice, first and foremost, is phototherapy. And then when it's severe, we do what we call an exchange blood transfusion, where we exchange the baby's blood for normal adult blood. Now, phototherapy is different from putting the baby in the sun. And we should please not advise mothers to put their baby in the sun until they have gone to hospital, the baby's jaundice levels have been checked, and then if they are mild, the baby can be sent home. And then even if you have done one jaundice test for the baby and it's mild, we need to do it again in the next day or 2 days later to be sure that it's not rising at an alarming level. And we continue to do this test until we are sure that it has fallen to levels that are not dangerous to the baby. So the picture there shows a baby who is under phototherapy light. This chart shows how the baby's bilirubin pattern, because as we treat, we also check the levels, and then we can plot them on a graph, and it will tell us whether the baby is dangerous or not. So management myths are exposure to sunlight. I've talked about it. Don't tell mothers to put their babies in the sun. Some people say give them glucose water. This is also very dangerous. When a baby has jaundice, one of the things we want them to do is breastfeed as much as possible. The first breast milk, which is colostrum, has laxative properties. And because of that laxative properties, it makes the babies to continue to go to toilet. And as the baby goes to toilet, a lot of bilirubin is even cleared through the stool. When you now replace colostrum with glucose water, you also deny the baby that benefit of clearing some of his bilirubin by breast milk. And then ampiclox drops are not a treatment for jaundice, because even if the baby has infections, he needs much more than ampiclox drops to take care of the infection. And then much more, we need to treat that jaundice properly. Bilirubin is neurotoxic, that is, it can damage the brain. And unfortunately, this damage usually will be irreversible. And then depending on the level of exposure, the effects can range from clinically undetectable damage to severe brain damage and even death. So by all means, we need to prevent or treat jaundice with a lot of aggression. So in the severest forms, we have what we call acute bilirubin encephalopathy. The baby is irritable, is lethargic, is feeding poorly. It can have seizures or convulsions, and then long-term, it can have a lot of neurological problems, including hearing loss. Okay. This picture shows a baby who has severe bilirubin encephalopathy. Once you see a baby lying in this position, it means that the brain has been affected, and he may not, is unlikely to recover normal neurologic function. So long-term complications include cerebral palsy, deafness, developmental delays, visual abnormalities, and low IQ. In conclusion, jaundice is a common problem even in our environment. It's more severe in babies born outside the hospital, and severity is aggravated by factors such as delay in getting to hospital, exposure to certain household items like naphthalene or camphor balls. When babies are discharged early from hospital without subsequent visits, they can have jaundice, which may not be noticed until it's too late. Complications can be prevented by early recognition and prompt treatment. Thank you. So can we take questions?
Thank you, ma'am.
Yeah. If you have any questions,
Yes,
you can
I have
ask.
a question.
Yes, please.
Yeah. Thank you. My name is Richard. Thank you for the lecture, Prof. I have two questions. Number one, in the first round before we had the network issue, you made mention that when we were talking about the warm chain, you made mention that babies should not babies do not need to have their bath or be weighed within 24 to 48 hours. But in that slide, when the network came back,
No.
you said these are the things that should be done within 90 minutes. I don't know whether I am the one mixing it up.
No, yes. So, no. Weighing should be done within 90 minutes. Because what we need is a birth weight, but not immediately after birth. But bathing should be delayed. Is it clear now?
Okay.
Yes.
It's clear now. Now that's the first question. My second question, you said something about the G6PD deficiency is greater in male. Why do you say so? What was the medical reason?
Okay, it's actually an X-linked disorder. It's
X or Y?
X-linked.
X. Okay.
X. Remember, males have only one X. Females have two.
Okay. Yes.
So it means that once the male has it on his X chromosome, it's going to manifest. Are you there?
Okay. Yeah, I'm there.
Now, yes. For the female.
Okay, then
usually.
Okay.
Yes. Okay. Go ahead.
Go ahead. No, go ahead. I'm sorry for stopping you.
So
you're
the
saying something for
females
the
will
female.
have, and so for the females, they have two X chromosomes, and usually one X is inactivated, right?
Yes.
So it's either that's one that has the G6PD, usually is inactivated, so they don't manifest it. And then even if they manifest it, it will not be as severe as in the male.
Okay.
Are you there? Yes.
Yes, sir. Yes. One more question. I saw in the slide you highlighted well baby. Is it a concept or it's the normal meaning of baby that is okay?
Okay, I said we're talking about physiologic jaundice.
Okay.
So I said for pathologic jaundice, once there is jaundice in a baby who is not well, that the baby has other problems like fever, rashes, poor feeding, convulsions, that baby is unwell. So whatever jaundice he presents with is pathologic. But for physiologic jaundice, the baby has no other problem apart from jaundice. I don't know if you understand.
So the baby is
So
well.
one of the criteria for saying that the baby has jaundice, has physiologic jaundice, is that the baby is well. He has
Okay,
no other
okay.
problem apart from this jaundice. And then I went on to emphasize that even with this physiologic jaundice, even if we assume, we must still check the levels to be completely sure that it's physiologic jaundice. So
Yeah.
once a baby has jaundice and is unwell, has any problem, it cannot be assumed to be physiologic.
Okay.
Yes. Thank you.
One more question.
Okay.
I'm sorry.
Go ahead. Go ahead.
Okay.
I can't hear you.
You said
Okay.
something that when the baby is delivered for the first 24 hours, several assessments need to be done. Then and recorded, as well as maybe recording the digits of the baby and kangaroo activity, kangaroo mother position care, and the rest. Now, my question is, if a mother gives birth to a baby, maybe in the same theater they were another delivery, and maybe there's an exchange of baby, either advertently or inadvertently, and there is exchange. If these parents they take the babies home, I don't know, maybe the question might be sounding funny. Is there a possibility that this baby is going to behave like these other parents that they took the child home or something? Maybe they didn't notice or something.
See, first and foremost, that exchange should not occur. You know, when babies are born, immediately after birth, they are tagged. You understand? They put a tag of the baby's identity on the hand or the leg immediately. Immediately the baby is born. That's part of the routine identification. So, for example, and we usually identify babies by their mother's names. So, baby Ngozi this is tagged on the baby. So, first and foremost, that exchange should not occur if we're doing things properly. Now, talking about if there's a mistake, whether it will be, they will behave like the other parents, you cannot know, but medically, there are certain things that may show. For example, if the baby is a sickler, has inherited the gene for sickle cell anemia, and the parents that he has gone home with do not have the S gene, there's already a problem. Because if two parents do not have the S gene, they cannot have a sickle cell child. So those are things that as healthcare professionals, we should be very careful about. Exchanging babies is something that should not even arise. And if it does arise, you can be sued because that is not a mistake that you should make. You'll be indicted for deliberately giving somebody's baby to another person. So at birth, and if you're attending to women at delivery, you cannot be attending to two women at the same time. It has to be one. At the time of delivery, it's one baby at a time. And so one of the things you do is immediately tag the baby and sort out that baby before you attend to another. Or better still, somebody else should take care of the other one. So, taking care of babies has to do with nature and nurture. Nature in terms of there are certain things that they have inherited. Nurture in terms of the environment where they are. So sometimes the environment where they are raised can do a lot in how the baby or the person behaves. So you cannot really say he's behaving like the other parents. He may behave like the parents that have raised him up because of the environment where he is. But when it comes to nature, there are certain things that cannot be changed. For example, the genotype cannot be changed. The color cannot change. So, I don't know. as much as I can say for now.
Thank you, ma.
You're welcome.
Good evening, Prof.
Yes.
Good evening, Prof. Thank you for the lecture. I'm
Good
best
evening.
man, Asuk by name.
Okay.
Uh,
All right.
I just want to ask this question. What if in a situation where a mother gave to birth and some complications arises to the fact that the baby was unable to take the colostrum, which is the first breast milk, and that continues for like a period of 24 hours in such a way that the baby cannot access his or her mother, and the baby was just left like that. What do you
Okay.
think can be done for such baby to still be active? Thank you.
Okay. So first of all, if there are two things, the mother may be too ill or the baby may be too ill to feed at the time of shortly after birth. Now, that colostrum, like I said, is referred to as liquid gold. As much as possible, every baby should have colostrum. For this baby that is too ill, there are certain things we can do for the baby. We take the colostrum from the mother, we apply it to the mouth, inside the mouth of the baby. It's very, very important to the baby. Baby is unable to feed, we help the mother express breast milk, and we can store it in the fridge until the baby is ready to feed. We do that a lot in the newborn unit. So whatever she can produce, we store it in the fridge until the baby is well enough to feed. But if for any reason the mother is too ill, or the baby, or the mother even dies, if the mother is not available for any reason, from illness or death, then we cannot deprive the baby of nutrition. We can use infant formula. But as long as the mother is available and we can get breast milk, we can store the milk until the baby is ready to feed. And we do that. Is it okay?
Okay, thank you, Prof. Although I have a scenario of that nature, and
Okay. What happened?
I know the thing that happened like marvels me because the mother has some complications in the process of delivery, and the moment she put to bed, the baby was taken away from her, and after some time, giving it to the parents of the woman, and we are trying to arrest the situation. And the process, the situation could not be arrested. And emergency surgery has to be done for the surgeon to be arrested. And all this while I'm talking with you, the baby has been left in just that manner for like a period of 24 hours without giving the baby anything at all. That was
No, that's not.
like, it's a scenario that happens to me. And I was like, I was not around. So when I came back, I have to start shouting at the doctors. The nurses were like, why? I say, I don't understand. Why will people leave a newborn baby for a period of 24 hours without giving any form of attention? And they are telling me the mother is not strong. How? That's other things are meant to be done. So at some point, they were
No,
asking me,
that's
are you a
wrong.
doctor? Yeah, are you a doctor? I say, this is my area. You people are doing something that is very wrong. And they were arguing, like in this, you picture to be specific. They were arguing with me, seriously.
Serious.
Yes.
Please, where was the baby? In the ward? Where was the baby?
No, as at then, the baby has not been taken to the ward because the mother was in a situation that they have to rush to the, okay, she delivered around 6:30 p.m. And we are struggling with her. I was not around based on the information she gave to me. Was struggling with her for a period till 12 p.m. Before they called me, they had to perform an emergency surgery. I was like, all this while, what have they been doing? As the baby feed, they said no. I was still wondering, and the surgery lasted for almost 4 hours, 30 minutes. Like they have to
No,
run it till almost 4:30 in the morning, and it was something else. I was wondering because I was like, they are lucky I was not around because we'll have had some issues.
No, we don't
It was
stab
just for the
babies
name.
like that. So sorry about that.
Yeah, and I was
Sorry
telling them they
about
are
that.
like arguing. So,
Hello, ma'am. Ma,
thank you,
Yes,
ma.
please. Thank you.
what of in the case of a cesarean section? You know, after
Mm,
the operation, the woman is taken to the recovery room first of all,
mm,
so that
mm,
so like the whole mother to child bonding does not really
mm.
occur. Sometimes it takes some women 6 hours before they come out from the recovery room. So is it that the baby has missed out in the bonding between
It's
the
like I said, it's when we're used to a way of practicing, we just continue like that. There's no reason to separate a baby from the mother for 6 hours because she had a cesarean section. There's no need. There's no reason. Why the separation?
okay.
The baby should be with the mother, and then that's why, we need to counsel these mothers ahead of time and tell them the importance of that, um, keeping mother and baby together so that their minds are prepared ahead of time. A lot of times we fail to counsel them. That is why they also get comfortable having their babies kept far away from them. If they know and the person who is managing them knows, we will keep mother and baby together. And that baby can start breastfeeding as soon as possible, whether she had cesarean section or not.
But
So
ma,
we
what
need
I'm
to.
asking, like I
Mm,
worked in UBTH, so the
mm.
theater, once the woman is taken out from the theater, the recovery room is far. Where they are keeping the baby is also far.
Those are the things.
The theater nurses will tell you the woman has to recover first before they move her to where they kept the baby. I don't know whether you
Mhm.
understand. Like
I understand what you're
I've
saying,
seen
but
it.
those are the things. Those are the things that we want to change. People need to be aware. And the thing about nurses is they hold on to things that they think they know, especially the older ones. So those are the kind of things that we're trying to change. And in
Okay,
some
ma.
places,
Thank
those
you.
things have actually changed. Yes. Thank you.
Hello, ma. Good evening, ma.
Yes. Good
Okay,
evening.
ma. Yeah, I have a question. I have two questions actually. So,
Okay.
the first one, you spoke about the care of the umbilical cord, where you mentioned that only chlorhexidine gel should be used for the care. But some hospitals normally still advise people to use moco spirits, like
Spirit.
yes, with cotton
Okay.
wool on the umbilical cord. Will you say it's the right thing, or is there any side effect to that? That is my first question. And my second question is, how long would it take for the umbilical cord to fall off after birth?
Okay. So first of all, um, using our national guidelines for newborn care, for essential care of the newborn now, the current guideline says we should use chlorhexidine gel. Hmm? As I'm sure a lot of us that work in the hospital we have seen chlorhexidine gel.
Yes, ma.
Previously, we were
Yes, ma'am.
using yes. So it was methylated spirit, but the current guideline says chlorhexidine gel. That doesn't mean that if there's no chlorhexidine gel, we shouldn't use methylated spirit. We can use methylated spirit. Important thing is to make sure that we're cleaning it in hygienic conditions. Then about how long does it take the umbilical cord to fall? It varies for different babies. It can be as early as 4 to 5 days. It can be as late as 2 weeks. For some babies, it even gets up to 21 days. There's
Wow.
actually, a lot of people get worried when it goes beyond a week. The cord is not falling. People get worried, but it can stay up to as long as 21 days. It's a wide variation. The important thing is when it's time, it will actually fall.
Okay, ma. Yeah. Thank you, ma.
Yes.
Good evening, ma.
Good evening.
Thank you very much for your lecture, ma. Ma, my question is on the vitamin K. Is it compulsory for every child, or are there
It's
indications?
routine.
Because I know that for
It's
my 3
routine.
babies, none of them were given vitamin K. That's one. Then
They're
secondly,
supposed to be
concerning the,
given.
okay, ma'am, because I had them in UPTH and none of them were given. Then concerning the chlorhexidine gel and umbilical and spirits, I actually tried both, and I will still prefer spirits because I don't know,
It
because I
falls
actually
faster.
purchased the chlorhex. Yes, it falls faster with spirit, and chlorhexidine gel, when I tried it, it makes the cord damp and all that, and it was taking quite long, and I went back to spirit and had results, so I didn't go back to it again. That's my personal experience. Thank you very much, ma'am.
Mm-hmm. Yes, I agree. It takes a bit longer for it to fall with chlorhexidine gel, but that's the national guideline. And outside the country, it's also chlorhexidine gel right now. Then, okay, vitamin K1. You know, for us in the newborn, we are always advocating that the baby should have routine. So whenever we push and push and push, they stock vitamin K1. And then they finish the stock. And then if we are not pushing, they don't give. So, you know, sometimes it's difficult because there are two different departments. But for those that come to the newborn unit, immediately they come, we give them vitamin K. And obstetricians are more interested in mothers than babies. So a lot of times when we go, we check, they'll say they don't have vitamin K and nobody is ready to stock it. But vitamin K is actually routine for every baby at birth. 1 milligram of vitamin K is routine. Thank you.
Good evening, ma'am. Good evening, ma'am.
Okay.
Okay, I have 2 questions to ask. Thank you for the lecture so far. So, can a preterm baby be vaccinated with the BCG, BV, and the OPV0 at birth? A preterm baby.
Yes. So once the baby is well enough to go home, you should have immunization. The only vaccines that we wait for them to get to at least 1.8 kg to 2 kg is hepatitis B. We want to give them that when they are up to 2 kg. Otherwise, once they are well enough to go home, they should start immunization.
Okay. Thank
Yes.
you, ma'am.
Good evening,
All
ma'am.
right.
Good evening, ma'am.
Okay, so we'll take 2 more questions. Time is fast spent. Okay.
Okay. All right, ma'am. Good evening.
Good evening.
Yeah, thank you for the lecture so far. So my question is actually a personal experience. When I had my baby, the baby was actually a little bit underweight, around, would I say underweight, around 2.4 kg. And I had the baby through cesarean section. When the baby came out, I first of all, when I have all my children, I look out for jaundice for all of them. So for this particular one, I looked at and I was, I was noticing I noticed some kind of, that the baby had jaundice. So I was waiting for the nurses and the doctors to, confirm my fears, but they didn't say anything. They did their observation and it looked as if everything was okay. And like on the second day after birth, the baby started jerking. We called the doctor. They now decided to check for the bilirubin level. And when they ran that test, they said the result came out and they said the levels were within range, that the baby did not have jaundice. The baby was looking sickly, pale, and all of that, in a very big hospital in Port Harcourt. Specifically, I don't want to call the name of the hospital. So we had to discharge from that hospital, took the baby to a pediatric, like a hospital that specialized with baby. And when we went there, immediately they repeated the test. They found out that the baby had jaundice at a very high level. So is it possible that a test to be run to check the bilirubin level initially, and they would find out that the baby does not have jaundice, and maybe a day later they find out that the baby have jaundice? Is it possible?
Yes. Like I said, when jaundice is pathologic, the rate of rise is very fast. So you can get levels within normal today. By tomorrow, it has gone very high. That tells you that something is really wrong. And that baby needs to be taken care of quickly. So it's possible. Very, very possible.
Good evening, ma'am.
Yes.
Good evening, ma'am.
Good evening.
Okay, so thank you so
Good
much,
evening.
ma'am. Yes, my question is, I want to take you back to when you were talking about link in the warm chain. Okay, you make mention of postponing, of battling, and weighing of a new baby. I want to talk about infants that their mother is HIV positive. Okay, where those infants should be provided with prophylactic at before 24 hours of birth. So what should be your advice? Because you were talking about 24 hours before you can now go to weigh-in. How do we go about that?
Okay, no. For those babies, mothers of infants, of HIV positive mothers, thank you for the question. Those ones, we don't postpone. We need to bath them, especially because they may have bloody secretions on them. In fact, if a baby has bloody secretions, that baby should be washed, should have a bath, especially if it's an HIV positive mother, because we want to reduce the risk of exposure as much as possible. And then weighing. Sorry, the bathing is within 24 to 48 hours, but weighing, if you remember the other slide I put, weighing should be at about 90 minutes of age.
Okay.
Are we clear?
Yes, ma'am. Thank you.
Okay, ma'am. Let me just ask a question. Good evening. Thank you so much for your lecture. It was quite interesting. Okay, so I just want to ask about the treatment for jaundice. I remember those days as an intern, a lot of doctors used to request cross-matching, grouping and cross-matching for new babies, neonates. And they were planning to do EBT, that's the exchange blood transfusion between the baby's blood and the mother's blood. So I want to ask, what are the success rates like? Do they actually, get through? Does it work, the EBT, just to treat jaundice? Thank you.
Yes, so now when the jaundice levels are high, too high, we want to do an exchange blood transfusion. We do what we call a double volume exchange blood transfusion. The blood we use must be compatible with both the mother's blood and the baby's blood. And it's not like the normal blood transfusion. It is an exchange. So for example, when we are doing the procedure, we exchange in aliquots. If it's a big baby, you take out 20 mils of the baby's blood, you push in 20 mils of the cross-matched blood until you exchange the total volume you want to exchange. So like for a 2 kg baby, you want to exchange about 340 mils. So you exchange in those small aliquots. You remove from the baby, you put back, you remove and put back. That's what the exchange is. By the time you do a double volume exchange, you have exchanged almost 80% of the baby's blood. So you have removed a lot of the jaundice from the baby. So it helps to bring down the jaundice levels very quickly, and it can be life-saving for the baby. So yes, we do a lot of exchange transfusions, and it's not usually a big deal. Yes, most of them are successful. Yes.
Okay, ma. Thank you.
Yeah.
Good evening, ma.
Good evening.
Okay, so my question is on jaundice. There is this misconception that jaundice is normally caused by untreated malaria during pregnancy. So that means there is nothing like that from your explanation so far.
No, if the woman has malaria, she has malaria. That's not the main reason for jaundice. I've told us the things that cause jaundice. If the baby has an infection, yes, it will break down his red blood cells. But that the mother has malaria doesn't necessarily mean that the baby will have jaundice. It doesn't.
Thank you,
But the
ma.
thing is, if the woman has fever in pregnancy, that fever may be malaria or maybe something else. It may be due to an infection. And if she has an infection around the time of delivery, that infection can be transmitted to the baby. And then the baby can subsequently come down with that same infection, and then it will break down the baby's red blood cells, and he may have jaundice. But it's not necessarily that the mother has malaria, so the baby will have jaundice. No. Thank you. All right. So I think we can call it a day.
Thank you, Prof.
Thank you, ma'am. We
All
can.
right.
Good night.
Thank
Good
you,
night.
Good night.
Thank you.
Night.
Thank you.
Thank you
Thank
very much.
you.
Thank you,
Your
Prof.
lecture
I
is
love you,
sweet.
Prof.
Well done.
Lecturer.
Thank you.
Thank you.
Good night.
Thank you.
There's
Thank
a question on the chat box.
Mhm.
Thank you.
Yeah.
Thank you, Prof.
Thank you.
Our young Prof is greeting you, Prof.
Our baby student is joining
Our
the
baby
class.
student has
Thank
in
you. All
There's a
right. Good night,
question.
everyone.
Good
Good night,
night,
Good
ma'am.
Prof.
night.
Night.
Yeah.
Ma.